Good afternoon, everyone, and welcome back from the break. Thank you again for your time today. I'm very excited to dive into one of my favorite parts of the summit, the innovation session videos. We all know, we're still mostly in a virtual environment. So in lieu of a traditional poster session, we issued a call for abstracts and interventions, and we'll be presenting in just a moment here a handful of videos of said submitted abstracts that were selected as top submissions. However, prior to rolling the videos, I'd like to take a minute to return to some of our finalists from 2021. Given this year's focus on implementation, we reached out to our finalists to ask a series of questions about how their work has proceeded over the past year. While the full information will be listed in the compendium, I wanted to highlight their answers to perhaps the most important question we asked. What are your recommendations for others developing or implementing addiction stigma reduction interventions? Their answers are as follows. First, it is imperative and critical to include those with lived experience from the beginning. We have heard this several times today, but the wisdom and the answer to reducing addiction stigma is to include and innovate with those who experience every day and to build with them and not for them. Secondly, it's critical to have a plan for sustainability and backup plans in case of unexpected barriers. We all know, obviously, 2+ years later, that the COVID-19 pandemic is a classic example of one of those barriers. But as far as sustainability goes, it's what does this look like in the future? Are we planning for 6, 12 months out, 5 to 10 years? How do we make these interventions sustainable? Build that in from the beginning as well. Third, gathering user feedback and testing the intervention is absolutely imperative. This goes for all types of interventions in all different systems. Does this have the intended impact? Are there unintended consequences or ripple effects that we didn't anticipate? Does what we thought work, does it work? Does it not work? If it doesn't, let's pivot and let's address those issues. But making sure to gather user feedback and testing prior to putting something out into the field is critical. Also, we must know our communities. It's so important to be culturally sensitive to the community that you serve. This knowledge and the sensitivity informs practice and ensures that the services and interventions recommended are acceptable and will truly benefit the community. Although we all work with communities to lower substance use stigma, the communities themselves still have the right and to decide what to prioritize for their community-based actions to lower substance. So know your community, know who you're working with. Fifth, education is key. Use trainings that use contact-based strategies, contact with people with a substance use disorder, contact with people who use drugs, use critical reflection techniques, local data, model respectful language, and explain things in plain terms. Education is critical, but it's not enough, and it's part of the broader awareness building components that we all need to focus on, but making sure that we're modeling it from top to bottom is critical. Lastly, include real-life examples and include a diversity of perspectives and backgrounds. This can all feel very theoretical. It can feel vague. It can also feel very, tangential at some points to other work that's being done, like, oh, we hope this reduces stigma as well as doing X, Y, and Z. What does it look to really do this? And that's part of what we're here today to do, is to show some of these real-life examples and to really look at a diverse selection of programs across the country. Again, we're so excited that these individuals, teams, and organizations submitted these abstracts that really showcase innovative programs, initiatives, strategies, research, and products that can be at any stage of the development lifecycle, from planning to intervention, but have the aim of reducing stigma for people who use drugs. And with that, thank you to all of our finalists for supporting these interventions. The real life experience will be invaluable, and I'm so excited to turn it now to the 2022 Innovation Abstract submission winners. Take it away.
Over 11,000 homeless individuals are cared for by Boston Healthcare for the Homeless program each year. We are committed to ensuring that every one of these individuals has access to comprehensive health care. Our clinicians, case managers, and behavioral health professionals work in more than 35 locations across our city to deliver the highest quality health care to some of our community's most vulnerable and most resilient citizens. Many of the patients we serve have substance use disorders. And while we strive to provide the best patient-centered care, We learned through a series of surveys and patient stories collected by members throughout our program that many patients are subject to stigmatizing language around substance use disorders, and it's used throughout our program, often unknowingly by our staff. A member of our community advisory board spearheaded this training program to be able to incorporate patient voice and lived experience to help our efforts in reducing the use of stigmatizing language around substance use throughout our program. The Language Matters training really worked on having the preface that clinical and non-clinical staff all have various levels of education around substance use disorders, which impacts the language used when engaging with patients from the time they walk in, receive their care, by the time they leave. So we developed an hour-long training that we offered to individual teams so they were able to apply this to their actual work and be able to inform staff on substance use disorders and stigmatizing language. The training is conducted by a clinical social worker and a member of our community advisory board. The training incorporates professional studies on stigma, as well as direct quotes from our patients to help it resonate more. The training also offers alternative non-stigmatizing language bank that staff are encouraged to use post-training. The project aims, we really hope to educate clinical and non-clinical staff on the training objectives to reduce stigmatizing language used in clinical care and during non-clinical interactions. Through educating our staff, regardless of role in our organization, we hope to decrease the stigma patients with substance use disorders face while receiving care and services in our program. And by having a member of our community advisory board lead this training and co-facilitate it with our social worker, we're able to use direct quotes from patients, and attendees will be able to resonate more with the material and be able to connect what they're learning in this training to the person that they're sharing the elevator with. The training objectives for all staff are to learn to view substance use disorders as a chronic illness and describe the effectiveness of treatment for substance use disorders, review the concepts of stigma and the importance of therapeutic language and presence to fully engage patients in care, and really to understand how stigmatizing language influences power dynamics, affects patient care, and how patients perceive the care that they have received. We really wanted to strive in incorporating patient voice. A member of our community advisory board conducted a simple 6-question survey to patients in our OBOT program. And we also conducted a community needs assessment in an open drug scene tent encampment where 100 people without housing who minimally engage in healthcare or treatment for substance use were asked how stigma impacts their engagement and care that they hope to receive in the future. The engagement of patients with substance use disorders is a twofold process. For patients with substance use disorders, we really wanted our staff to realize that this becomes internalized. It reinforces trauma and distress, leads to negative views and mistrust of healthcare workers, and often leads to avoidance and fear of presenting for help, leading to minimal care. And for providers treating people with substance use disorders, we wanted them to understand the greater levels of implicit bias when stigmatizing terms are used to describe patients. There's a strong recommendation that we remove terms from documentation and medical charts to reduce implicit bias of other healthcare centers that may be receiving our notes via electronic medical records, and how substance use is discussed with the patients and how healthcare professionals need to use better language to help people recover from substance use disorders if that's what their goal is. Post-training, clinical staff were able to receive CEUs after completing the survey, and non-clinical staff were able to receive a certificate of completion for their HR file. Our anticipated results and goals: as more teams participate in the training, we hope that stigmatizing language used throughout the program will be replaced with patient-centered, non-stigmatizing language, that initiation, engagement, and treatment for substance use disorders will increase for patients in our program. We hope to conduct yearly patient surveys on stigma, and that these surveys will show decreased stigma patients feel regarding substance use disorder while accessing care in our program. And that all staff will be trained on the impacts of stigma at new employee orientation and yearly refresher courses.
Hi, I'm Julie.
I'm Sarah.
I'm Brittany. We're from Cook County Health and excited to talk today about patient-reported outcomes in substance use disorder care. At Cook County Health, we serve patients in Chicago and suburban Cook County. We're comprised of 2 hospitals, 12 community health centers, the local health department, care at the Cook County Jail and Juvenile Detention Center, and County Care, one of Illinois' largest Medicaid health plans.
Our substance use disorder programs at Cook County Health support patients in our emergency room, inpatient, 12 community healthcare centers, and Cook County Jail. Overall, our SUD program goals are to support patients to actively achieve their recovery goals, to improve the physical, mental, and social well-being, including reducing the risk of substance use, and to overall reduce the risk of fatal overdose from opiates.
Here at Cook County Health, our team consists of the medical provider, recovery coach, and social worker. We use a patient-centered approach, working to identify patients' needs and meeting them where they are. Meeting patients where they are allows them to have more control over their recovery, resulting in better recovery outcomes.
The problem we're trying to address with our project is that medical providers are often taught that in substance use disorder care, abstinence is the only goal, it's readily attainable, and it's easy to sustain. We know that's inconsistent with the current understanding of substance use disorder care and our patients' experiences. It's unfair to patients, and it sets up providers with unrealistic expectations. Only providing care teams with urine drug screen results as the main outcome limits their ability to see success for patients. Our project aim was to broaden that, to provide teams and patients with more data to understand successes and challenges in their substance use disorder care.
In 2017, we created clinical documentation tools in our electronic medical record in order to help teams be able to understand fully different data points besides just a urine drug screen. To do so, we utilized the PROMIS scales from the National Institute of Health for patient-reported outcomes. After launch, we realized just how difficult it was, however, to read through all of that data and for teams to really use that information clinically. It sometimes became buried in clinical notes and really became difficult for teams to track that information over time.
To address this and make the patient-reported outcomes data more actionable to team members, we transferred the sentences in clinical documentation into easy-to-understand visuals embedded in the electronic medical record. So here's an example of a patient's reported ability to participate in social roles and responsibilities. The questions are listed on the left, and you can track from left to right and see the size of the bars and the colors of the bars change, helping to illustrate successes and challenges and changes over time. Our first step to understanding if this project is successful is to measure how often these tools are done. What you can see here is that since launch, we've seen a steady increase in tools and therefore dashboards being created.
Patient-reported outcomes help patients to identify goals supportive of recovery. For example, a patient recently returned to use. The medical provider, myself, and the social worker connected and utilized patient-reported outcomes to help identify other areas in his life where he was more successful. This particular patient did have stable housing, employment, and a support network.
Now that we've launched our pilot, our next step is to talk to the users and understand what's working. So we're going to talk with medical providers, recovery coaches, and patients, understand what they like, what they don't, what's easy to understand, what they want more of and less of.
We'd like to thank all of our team members and collaborators that were a part of this effort. We'd also like to thank our grant funders who allowed us to do this work. If you're doing any of this work yourselves or have any questions, we'd love to hear from you. Thank you.
Emergency. Hospitals are violating federal law by denying required care for substance use disorders in emergency departments. At the Legal Action Centre, we use law and policy to build health equity for people with substance use disorders. And like much of our work, our campaign for emergency departments' adoption of evidence-based practices for people with substance use-related conditions began in response to a problem. Imagine, Taylor overdoses while using heroin. Her neighbor finds her unresponsive and calls EMS to take her to the ED. When there, staff give her more naloxone, monitor her breathing, rehydrate her, and give her medication for her withdrawal symptoms. Taylor tells the ED doctor she's overdosed many times, but once she's alert, the doctor simply discharges her with a list of local treatment programs. Later that evening, she overdoses on heroin again, and her neighbor finds her unresponsive and calls EMS. But this time, Taylor dies en route to the ED. It's important to contextualize stories like this in a broader landscape. EDs are key access points to substance use disorder care, but many do not provide evidence-based practices for SUD. And this is all occurring at a time when overdose deaths have reached an unprecedented high, and racial disparities in overdose deaths and access to care for opioid use disorder and other substance use disorders persist. We also know that stigma and stereotypes play an outsized role in the overdose crisis. As Dr. Catherine Hawk and her fellow authors wrote, stigma is often unwitting, unrecognized, and unaddressed by physicians. Providers often stereotype people who use drugs as quote-unquote undeserving of care because they view these people as folks who don't have a medical condition, but instead have substance use disorders thanks to their own choices, or for whom medication for opioid use disorder is simply substituting one drug for another. But we know that stigma is dangerous. Research has found correlations between stigma and decreased provider engagement, negative patient outcomes, patient avoidance of care, and we know that people with intersecting identities often experience multiplied and amplified stigma. Relying heavily on the work of provider advocates and researchers, we identified 3 evidence-based practices for substance use disorder, all of which have been incorporated successfully into emergency departments across the country. These practices include: first, screening for and diagnosing substance use disorder; second, offering to administer buprenorphine to patients in opioid withdrawal and/or with untreated moderate or severe opioid use disorder; and third, providing a facilitated referral or warm handoff to community-based SUD treatment alongside naloxone for patients who use opioids or drugs with which opioids can be combined. LAC wants to be part of the solution, so we've brought our legal expertise to bear by identifying 4 federal laws that can act as legal hooks to require EDs to offer these practices. These include EMTALA, the Emergency Medical Treatment and Labor Act, the Americans with Disabilities Act and Rehabilitation Act, both of which prohibit disability-based discrimination and protect people who are currently using drugs from discrimination when accessing healthcare services, and finally Title VI of the Civil Rights Act of 1964, which prohibits discrimination on the basis of race or ethnicity. All of these laws are aimed at removing the harmful effects of stigma and stereotypes. As part of LAC's ongoing ED campaign, we're focused on empowering directly impacted folks and advocating with providers, hospitals, and policymakers for integration of these practices into the ED. We're empowering folks to file complaints with regulators when EDs don't offer these services. This means educating diverse communities about EDs' legal obligations for substance use-related conditions and developing helpful resources, including our Be Empowered Guide for people who use drugs and alcohol, which illustrates common ways EDs can violate federal laws when they don't offer these practices, identifies actions patients can take if the ED doesn't offer these practices, and provides information on how to file complaints with regulators. We're also asking folks to share their stories of ED treatment for substance use-related conditions in response to our survey, which is linked here. And we're encouraging folks to reach out to us directly via email as well. Additionally, we're collaborating with peers to collect stories and highlight the importance of peers in reducing stigma and increasing advocacy for people who use drugs in the healthcare system. We're also advocating with ED providers, hospitals, and policymakers for ED integration of these practices, maximizing and driving momentum at all levels of government for change, and focusing on applying a health equity framework to the overdose crisis. Thank you.
Hi, I'm Jennifer Murphy. I'm an associate professor of criminal justice at Penn State Berks. My colleague Brenda Russell and I have put together this presentation on educational trainings to reduce college students' stigma. There are two components to our presentation. One is an in-person training session we did with students in February 2020, and the second is an on-campus media campaign that took place over a couple of months in the fall 2020 semester. Both of these efforts were in an attempt to improve addiction knowledge and decrease stigma among college students. The educational training session was an in-person session that lasted about 3 hours. We had about 40 students take part in this session, 33 that we had data for completing both the pre-test and the post-test so we can analyze the results of the impact of this training session. We targeted majors in criminal justice, psychology, and rehabilitation and human services. The reason that we targeted those majors is that we believe these are students who will likely enter professions where they will encounter someone with a substance use disorder. They're very likely to. And we thought it would be innovative to do stigma reduction work while they're still students, so before they've actually even entered these careers, so that we can build that empathy, reduce that stigma even before they're on the job. This 3-hour session had multiple components. We had a local physician who specializes in addiction medicine talk about the science of drug addiction, talk about drug treatment, talked about the disease model of addiction. We had several speakers who had lived experience with addiction and recovery. We had a local police officer talk about an initiative that the police were doing where they visit overdose survivors and try to engage them in treatment. We had someone also talk about the warm handoff programs that were happening at local hospitals. And we also spent a significant amount of time doing a naloxone training session. So students learned how to use naloxone correctly, and then they were given the opportunity to take home naloxone after the session. Our pre and post tests showed that this session had good results in decreasing stigma and improving knowledge about addiction and support for the disease model. The largest effect we saw was that students improved their comfort and knowledge around using naloxone post-training. And in addition to comparing the pre and the post-test surveys among the students completed this session, we also had a control group of students in those same majors who did not participate in the session, but took the same instruments that we could compare. And we also saw positive results compared to that control group. Because the pandemic shut down campus for the rest of the semester, we weren't able to replicate these training sessions throughout the semester like we had hoped to. So we then developed a virtual training where we cut down a lot of the 3-hour sessions into a 1.5-hour pre-recorded video that students could access. And this is an ongoing project now where we're still collecting data among students at many different Penn State campuses who can look at the video and complete the pre and post test surveys to determine whether or not we see stigma reduction there. The other component I want to talk about is the media campaign then that we did on campus. We had several students develop materials and distribute them around campus aimed at reducing stigma. Here's some examples of the flyers that the students created. These flyers were hung around campus and they were circulated over a couple of week period where they would be changed so that students weren't always just seeing the same flyers in the same spot. We developed some of these into larger posters. We had those around campus as well. On the television screens in common areas, we showed closed caption videos from the Story Powered Initiative, which is an effort that was started at Penn State Abington, where they recorded people talking about their experiences with addiction. So these stories were shown on television screens across campus. And Penn State Berks also showed some of these materials on their website during the campaign period. So we did see some positive impact of this campaign as well. So we're hopeful that having these kinds of efforts on campus can reduce stigma among college students. Thank you.
The title of our initiative is Overcoming Stigma in Pregnancy and Parenting, the Power of Peer Doulas. I'm Dr. Ruchi Fitzgerald. I'm a family physician and addiction medicine specialist here at PCC Community Wellness. I'm excited to introduce some of our team members that you'll meet in this video, so you can learn a little bit about their innovative work here at our health center and in the community.
PCC Community Wellness Center is a community-based clinic in the west side of Chicago. Our specialty substance use treatment center is grant-funded for 2 peer doulas. These peer doulas support pregnant and parenting persons with substance use disorder longitudinally in pregnancy and in their postpartum period.
Peer doulas are both peer support specialists and doulas. Doulas protect patients from obstetrical violence and medicalized racism. Peer support specialists protect our patients from the violence of stigma.
When our patients are encountering our peer doulas here for our services, they're encountering people who have the lived experience, but who have gone through training because they're passionate about the community that they serve.
I decided to become a peer doula because I've experienced a lot of the discrimination that people who are using substances see and are traumatized by, and I wanted to be able to advocate for others so that nobody has to feel that way. I get to do the work that should have been offered to me when I was pregnant, having a baby.
I became a peer doula because I believe that women who use drugs deserve to be treated just like anybody else and deserve really good care. I believe that they deserve to have beautiful births. I believe they deserve to feel empowered and to have their birth be a powerful, transformative moment, just like any other mother.
I absolutely love my job. I love supporting and advocating for pregnant women with substance abuse issues. Not to have anyone and then to have someone to be with you while you're having your baby and support you is extremely important to me. And I know it's important to the ladies that we serve.
What makes our PPW program special is that pregnant women who use substances are one of the highest risk medical populations, and we really provide care to them that allows them to come to our clinic and interact with providers and support people who are non-judgmental and who are going to help them get the best care that they need.
And we get to provide that care to people no matter what their situation is, because everybody deserves care.
I loved having a doula. It was great. When I first found out I was pregnant, I know I was like scared and nervous and worried, but when I first met Carly Ann and then she introduced me to Michelle, it was great. I mean, they've helped me with a lot of services, and she was with me during my birthing experience, and now I have my son and they're still there, and after 4 years of coming here, it's great.
I just can't be more proud of the work that our peer doulas have done. It's been transformative, both for our families and for our healthcare system.
Thank you, everyone, so much. And thank you in particular to all of the people and organizations who submitted for our innovation session abstract process. We will make the videos of the finalists and winners available to all registered attendees of the summit in the coming weeks, as well as the compendium of all of these submissions combined. We will now be taking a 10-minute break before our final session, which will begin at 4 p.m. Eastern Time. Our closing plenary will be occurring in this tab within the video stream. I look forward to seeing you all in 10 minutes. Thank you.